Good morning, good afternoon, good evening, everyone. My name is Gergana Ralenekova, and it is my great pleasure to welcome you to today's webinar, Stroke and Needs and Numbers, part of the WSO webinars focusing on stroke prevention. This webinar series is organized by the WSO Global Policy Committee. The webinar today will run for 1 hour and a half. We are recording, and in a few days, the recording will be available on the WSO website. Today, we have 4 speakers, and at the end of the presentations, there will be Q&A session. Please don't forget to send us your questions during the webinar and using the Q&A function on the bottom of your screen. It is now my great pleasure to introduce the speakers of the webinar today. Professor Valerie Fagan, Director and Professor of the National Institute for Stroke and Applied Neurosciences, Faculty of Health and Environmental Sciences at the University of Auckland, and Affiliate Professor of Global Health at the University of Health Metrics and Evaluation at the University of Washington. Professor Gary Ford, Professor of Stroke Medicine at Oxford University, Consultant Stroke Physician at Oxford University, Hospital Foundation Trust, and Chief Executive Officers of Oxford Academic Health Science Network. Professor Bon Orvik, Professor in Neurology at Lund University, past President of the World Stroke Organization, and Professor Mayowa Oolabi, Lead Co-Chair, World Stroke Organization, World Health Organization, Lancet Neurology Commission on Stroke. Now it is my pleasure to give the word to Professor Valerie Fagan. Valerie, to you.
Thank you, Gergana. I will share my screen first. Dear ladies and gentlemen, dear colleagues, I am Valerie Fagan, Professor of Neurology and Epidemiology at Auckland University of Technology, New Zealand, and it's my great pleasure and honor to give this presentation today at the WSO Global Policy Committee webinar. The Global Burden of Disease Study, or GBD, is the largest global epidemiological study and repository of epidemiological data. The data are presented for 204 countries, for 379 diseases and injuries, and 87 risk factors. For several countries such as United States, Brazil, UK, India, China, data are presented at subnational level as well. The major advantage of the GBD study is that it allows estimates for countries and regions with no epidemiological data on a particular disease or injury or risk factors. This is achieved by using a sophisticated statistical modeling technique for estimating incidence, prevalence, different outcomes, and this mode for non-fatal outcomes, the accuracy of which is regularly improved. Most of the data are presented in the format from 1990, thus allowing evaluation of trends of the burden estimates. Also, the repository of data is updated annually with new epidemiological and other data collected, grouped in a particular format and entered into the GBD database on a regular basis. Therefore, each subsequent GBD estimates on a particular disease or risk factor supersede all previous estimates reported. Given the comprehensiveness, robustness, and up-to-date nature of the GBD estimates, by agreement, GBD Coordinating Center in Seattle, Institute for Health Metric and Evaluation, these estimates are currently used by WHO in regular reporting to WHO member countries. All available data sources are being searched for stroke epidemiology data using broad search terms for stroke, such as acute cerebrovascular accident, acute cerebrovascular disease, etc. For GBD 2019, we used data from 3,686 vital registration sources, 147 verbal autopsy sources, 368 incidence sources, 117 prevalence sources, 229 excess mortality sources, almost 8,000 risk factor exposure sources, and almost 3,000 risk factor relative risk sources. And for further details or data sources, you can use the link shown on this slide. Currently, only first ever in a lifetime strokes are reported for incidence estimates. But for mortality estimates, it is impossible to determine in the current GBD methodology when stroke has happened. Therefore, it is possible that stroke happened a few years ago, but as long as it is included in death certificate as first or second cause of death, it is counted as fatal stroke. Therefore, in some cases, stroke mortality estimates might be actually greater than stroke incidence estimates, which is illogical, although we realize that it is completely illogical, and currently Professor Greg Ross and his team at the Institute of Health Metric Evaluation trying to rectify this issue. Thus, at this moment, it is not appropriate to calculate case fatality based on the reported incidence and mortality rates. Currently, we use ICD-10 codes for stroke deaths, but for some countries, ICD-9 codes are also used with appropriate transformation into ICD-10 codes. TIAs on death certificates are coded as strokes, and deaths are coded as due to non-ruptured aneurysm are coded as intracerebral hemorrhage. The GBD researchers working at the Institute of Health Metrics Evaluation search for not only published but also unpublished data, some of which are listed here. Currently, GBD has an agreement with a large number of Ministry of Health across the globe who provide them with various epidemiological data GBD uses for statistical modeling. Incident stroke is only considered from the time of occurrence through the 28th day. Any stroke after 28th day of occurrence is considered as a chronic or prevalent stroke. This is slightly different from the conventional epidemiological definition of prevalent stroke, and this should be taken into account when interpreting the GBD stroke estimates. Neuroimaging data are used to classify strokes into three major pathological types. Other than incidence, mortality, and prevalence, the GBD study also provides three other burden estimates: years of life lost, years lived with disability, and disability-adjusted life years lost, or DALYs. Years of life lost are simply years lost due to premature death. An example shown here of how it is calculated. Years lived with disability are years lived in less than ideal health. It is calculated by multiplying the number of incident stroke cases by disability weights for stroke and average duration of stroke in years until death. Let me now show you disability weights for stroke used in the GBD study. Based on expert advice and survey results, the following weights were assigned for the lay description of health state of acute and chronic prevalent stroke cases. These weights are used in the calculation of years lived with disability. DALYs are simply the sum of years of life lost and years lived with disability. Arguably, it is the most comprehensive indicator of the burden of disease because it reflects healthy life years lost, mortality, and incidence estimates. Based on the epidemiological similarity and/or geographical closeness, GBD classifies all countries into 21 regions shown here in different colors. These regions grouped in 7 GBD superregions shown in the legend to the map. For example, the high-income regions covers a group of 34 countries in different parts of the world. The whole GBD stroke collaboration, which is currently has over 400 experts from over 50 countries, is coordinated from the Institute Health Metrics Evaluation in Seattle under the direction of Professor Craig Gross. But our institute at Auckland University of Technology is closely involved in this process. We recently established a GBD-affiliated neurological center at our institute that provides estimates for 5 neurological conditions and contributes to the GBD mortality estimates. From 2016 onwards, stroke remains the second leading cause of death globally, accounting for 11.6% of total deaths just after ischemic heart disease, and the third leading cause of death and disability combined. 5.7% of total DALYs after neonatal disorders and ischemic heart disease, which account for 7.2%. In 2019, there were over 12.2 million incidents and 101 million prevalent cases, 146 million DALYs due to stroke, and 6.6 million deaths from stroke. Let me now share with you some of the most recent GBD stroke burden estimates for 1990-2019 period. The data I'm going to share with you are presented in our recently published Lancet Neurology paper. Due to the time restriction for this presentation, I will focus my presentation primarily on estimates of burden and risk factors for total stroke. According to the most recent GBD estimates, there is a huge and increasing stroke burden in the world. As you can see here, age-adjusted stroke incidence, mortality, and prevalence rates have declined significantly from 1990 to 2019 by 3% to 36%. But the absolute number of people who develop stroke has increased statistically significantly over that period of time by 43 to 85%. In 2019, stroke struck over 12 million people, 7 million people died from stroke, and over 100 million people now live with stroke aftermath. There were significant fourfold between country and regional variations in the age standardized incidence rates across the countries. The highest rates were observed in Eastern European, Asian, Pacific and African countries, the lowest in high-income countries. If you look at the age-standardized stroke incidence rates in 2010 and compare it with that I just showed you in 2019, you will see that stroke incidence rates in low to middle income countries continue to increase, actually representing a stroke pandemic in those countries, while in developed countries the rates have decreased. A similar situation is observed with the disability-adjusted life years lost. It also means that the economic burden from stroke continues increasing. More clearly, it is shown in these figures that age-standardized stroke incidence, prevalence, mortality, and deaths tend to decrease from 1990 to 2019. However, over the same period of time, the absolute number of incident strokes increased by 70%, prevalent strokes by 85%, deaths from stroke by 43%, and deaths due to stroke by 32%. What does it tell us? It tells us that currently used primary stroke prevention strategies are either not used widely enough or evenly across all countries, or they are just not sufficiently effective, or both. It also tells us that pressure on stroke services has increased dramatically over the last 30 years. Global distribution of age-standardized stroke-related deaths attributable to all 19 stroke risk factors analyzed in the GBD shows a remarkably similar pattern with that for age-standardized stroke incidence rates. It suggests a close correlation of the analyzed risk factors' prevalence and significance with the risk of stroke. However, as you can see here, the relative significance of risk factors for stroke in different GBD regions are quite different, suggesting the need for regional specific approach for defining priorities in primary stroke prevention. From 1990 to 2019, the largest increase in age-standardized stroke population attributable fraction was for high BMI, increasing from 15% to 24%, statistically significant increase. In other words, if high BMI exposure will reduce to its theoretical minimum risk level, there would be a 24% reduction in stroke in 2019. Other risk factors with increasing age-standardized stroke population attributable fraction include high systolic blood pressure and high fasting plasma glucose, approximating diabetes. In contrast, from 1990 to 2019, the stroke population attributable fraction of ambient pollution and dietary risk has decreased. In 2019, the 5 leading specific risk factors contributing to stroke death and disability combined, or DELIS, were ranked in descending order: high systolic blood pressure, high BMI, high fasting plasma glucose, ambient pollution, and smoking. In summary, the GBD study shows that while stroke are largely preventable, as indicated by declining incidence rates, stroke remains the second leading cause of death and third leading cause of death and disability combined in 2019. Without wider implementation of population-wide primary stroke and cardiovascular disease prevention strategies, the burden of stroke is likely to continue growing, disproportionately affecting low to middle income countries. As the 19 analyzed risk factors for stroke are common for other major non-communicable disorders, Appropriate control of these risk factors will also reduce the burden of coronary heart disease, vascular dementia, type 2 diabetes mellitus, and even some types of cancer. Further research on frequency, outcomes, and determinants of stroke and its pathological types in different locations and over time is warranted. Such research could include identifying the highest risk population as well as further investigating differences in stroke pathological types and their geographical patterns, all of which would be useful for more targeted prevention and treatment efforts. Closing gaps between high-income and low-middle-income countries in the adaptation and implementation of internationally recognized guidelines and recommendations for reducing stroke morbidity and mortality, with the emphasis on primary prevention strategies, is absolutely vital to making serious progress on reducing the stroke burden pandemic. Thank you for your attention.
Thank you very much, Valerie, for the interesting presentation. The topic of the next one is most promising strategies for adoption of innovations in stroke care, delivered by Professor Gary Ford from the United Kingdom. Unfortunately, he could not join us live, though if you have any questions to Professor Ford, please type them in the Q&A section and we will make sure that he receives them and answers them.
In this presentation, I'm going to look at the strategies one can adopt to support the spread of adoption of innovations in stroke care. If we look at the evidence-based innovations we have in the last 30 years, they're substantial, and it's important we try and deliver these to all of our stroke population who can benefit. This table, adapted from publication by Gilligan in 2005, shows the absolute benefit that individual patients get from these elements of care, but also the benefit you get at the level of the admitted stroke population. And these are important issues to think about when you look at which innovations to support to give you the maximum value. So although thrombolysis and thrombectomy give the greatest benefit at the individual patient level in terms of likelihood of outcome, acute stroke unit can be applied to many more patients. So you achieve more of the population health benefit in terms of reducing death and disability from ensuring all patients receive acute stroke unit care rather than focusing on thrombolysis alone. The literature suggests there's a long gap of, on average, around 17 years between research evidence emerging and then this being adopted widely in clinical practice. And this was the cellular experience in the UK of the adoption of stroke units and thrombolysis. With stroke units, the first meta-analysis came out from Peter Langhorne and colleagues in 1993, and it wasn't until 19 years later, in 2012, that 90% of patients in English stroke services were accessing stroke units for most of their hospital stay. And similarly with thrombolysis, our own service and two others in Scotland started providing thrombolysis in 1998. But it wasn't until 2012 that 5% of all patients with ischemic stroke in England were receiving thrombolysis. And we've now got up to 11%, although we know the opportunity is around 20%. Now, if you look at country variations, you see even a greater variation in uptake. So here we see data from 2016 showing good uptake of access to thrombolysis and stroke units in some European countries, mostly in the better resourced, better developed northern Western countries, but in Eastern European countries in particular, very poor access of patients to either thrombolysis or stroke unit care. The literature on what helps innovation spread is worth thinking about. The These are 5 factors which have been described by Rogers. And these are the relative advantage of an innovation, how it's perceived to improve on existing practice, its compatibility with existing values and practices. This is quite an important aspect, and you see it playing out in different ways in different cultures. But for example, if hypothermia had been shown to be effective in acute ischemic stroke, it would be quite a difficult innovation to adopt in some countries which have little in the way of the provision of high dependency unit beds. And similarly, mobile stroke units have been easier to adopt in countries which find it easier to deploy medical staff onto ambulances and others that don't. Key aspect is simplicity and ease of use. The easier you can make it to use an innovation, the more likely it is to be adopted. The 4th factor is the trialability, which is not the randomized controlled trial evidence, but the degree to which an innovation can be tried out by healthcare professionals. And I think this is quite difficult with many of the things we need to provide, such as stroke unit care or thrombolysis, where you need to put a whole pathway in. But if people can try new approaches, that helps getting adopted. And then the final factor is the extent to which the results are observable in individual patients. So I think in this regard, where one can see the effect of reperfusion treatment, like with thrombectomy, or if one sees thrombolysis open up an artery using CT angiography, and you see a clinical improvement occur rapidly, that helps sustain innovations. But of course, many of the treatments, because stroke has a variable outcome at an individual patient level, it's hard to determine what the innovation has had in terms of the impact on the individual. So these factors determine up to 80% of the variation in the adoption of new products in general in healthcare. It's very helpful if there can be a national or regional stroke strategy in place. The National Stroke Strategy, developed in England in 2005, really helped drive improvements in access to stroke units and thrombolysis. And there's a similar stroke plan, for example, in Australia. And I think this helps drive local healthcare systems and hospitals to support the uptake of innovation. It's really important to have good data on what is happening with the uptake of innovation. If you don't have that, it's very difficult to manage and direct resources appropriately to support innovation uptake. There are some very good examples of this. The USA Get With The Guidelines program has been very successful and has lots of published studies showing the impact and variation and improvements. The UK has the Get It Right First Time program in a number of areas, including stroke, which uses benchmarking and reviews of services, and supported by the Sentinel Stroke National Audit Program, which has been running for many years, to which all hospitals that provide stroke services contribute. And this has been very helpful in individual teams being able to see how the quality of their care compares to other teams. And for much of healthcare practice, there is not reliable data to inform individual teams and hospitals how good their services are. If possible, it's worth putting efforts in developing communities of practice or clinical networks. These are similar structures. Managed clinical networks rose in the UK, and where healthcare professionals and organisations are linked with managerial support to try and ensure equitable provision of evidence, high-quality services. And these were very effective in driving improvements in stroke care in the period 2005 to 13. Community of practice is really very similar. It's a group of people who share a concern or passion for something they do. And I think these are really important to think about in terms of spreading best practice. These can be done virtually. For example, the Toronto Stroke Networks has a virtual community of practice. And there is a literature on how to develop community of practice and support them, and how to structure them. This is one such paper which talks about building an MD team in stroke team, developing practice-based knowledge, so capability in healthcare staff, looking at the organizational climate and culture and how you deal with opposition to change, and recognising and value the key roles of certain staff. Developing and identifying champions, both clinical, managerial, and patient and community, is also very helpful in supporting the uptake of innovation. Champions assist in getting adoption taken up faster, in talking to skeptics, helping support people who are thinking about introducing innovation. And they are key in overcoming system barriers and improving staff motivation. And in all the work we drive, we always look to have clinical and other champions. There are different types of champions. Ideally, you want a range of champions. Executive champions will be sitting at board level positions in organizations, so they are accountable at that level for ensuring a program is implemented. Managerial champions are important to support clinicians and would be typically the senior managers in clinical departments or units, and then clinical champions of frontline clinicians. There's also a recognition that patient champions and patient organizations are key in helping drive uptake. They're very important in influencing politicians and healthcare planners and have an important role in engaging with the media, all of which is helpful. One of the things that is really useful to help drive implementation is the delivery of how-to guidance, how to actually introduce innovation. Most evidence-based guidelines say what to do, but not how to do it. And if one can, it's worthwhile developing locally relevant, easily accessible online guidance, accompanied by case studies, which clinicians and teams often find very useful to draw upon. Academic publications are less helpful, particularly to non-researchers, because unless they're open access, they're often behind a paywall and not accessible. And they often lack the practical details of how changes were made in services to adopt innovation. We've produced some practical guidance for mechanical thrombectomy in the UK, and the WSO has produced a roadmap for quality stroke care, which is certainly worth looking at in terms of looking at how you adopt best evidence-based innovation into practice. Also, you often can produce this rapidly if you bring in writing support. We use a medical writer to help produce these guidelines. We produce within 8 weeks on each occasion to help healthcare professionals respond to the pandemic and how to organise stroke care. And we did this with the engagement of the relevant professional groups, including the British Association of Stroke Physicians, and a number of different healthcare systems around the world have done similar initiatives. And this is very useful for teams to draw upon when they're looking at how to make rapid change, as introducing virtual clinics for TIA or implementing telemedicine. When thinking about innovation adoption, it's useful to try and identify different teams and hospitals on the Rogers innovation adoption curve, whether they're innovators, early adopters, the early majority, late majority, or laggards. And the approach needed is very different for each of these in our experience. For innovators and early adopters, you need to provide support to help them achieve what they want to. Early majority and late majority, you often need to do a little bit of challenge. In the UK, the expression is comply or explain. So sort of ask why they've not adopted evidence-based innovations in guidelines and try and support, but also challenge them. With laggards, these can be very difficult. These are services that are often poorly organised or teams who are very resistant to any change, and you need to take a more regulatory approach. So you need different types of approaches, different organisations to deal with getting adoption into all of our healthcare system. One key thing is the benefits of innovation, and we've seen this in stroke care around reperfusion therapies, are only realised if you can optimise clinical pathways. And obviously this is key in terms of the timely delivery of thrombolysis and thrombectomy. You need to have a whole pathway of care from recognition of symptoms, pre-alert of patients by ambulance services, the whole ED process of care being rapid to deliver treatment as quickly as possible. Also, in thinking of innovation, any innovation that reduces demands on hospitals reduces length of stay. This is clearly where reperfusion therapies make a very strong case. Or reduce the demands on healthcare professionals' time is really beneficial because of the global shortage of healthcare professionals. And also innovation that is supported by empowering patients to monitor and deliver their own care is very valuable. And probably in stroke care, the biggest opportunity around that is around blood pressure measurement in primary and secondary prevention of stroke, but also to some extent around models of rehabilitation where families provide some support and patients deliver their own therapy. An example of the importance of pathway change was the situation we had in Newcastle when we've been delivering thrombolysis when I was there for 7 years. We had a very slow pathway to get patients to the scanner. Patients were triaged by an ED nurse. They then notified the stroke resident. They were required to discuss the patient with the on-call stroke consultant before radiology would consider agreeing to do a scan. And sometimes the radiology registrar would refuse to do the scan on usually very weak grounds. The call would come back to the on-call stroke consultant, was often me. They would then speak to the radiology registrar, be rather annoyed. The scan would be, of course, agreed to be done. The radiographer would be notified. They would contact the ED triage nurse, and then they would bring the patient into the scanner. But this took a long time and a lot of time of multiple healthcare professionals. And at the time, my son was 13, and he would sometimes answer the phone, and the hospital would say, "This is the hospital, can we speak to Professor Ford?" And he would just say, "Get a scan," because he'd heard me say it so many times. And he's got, as you can see, Down syndrome with moderate learning disability, and so he was quite clear what to do, but the NHS was incapable of doing it because of all these barriers to try and minimise workload in radiology. And as visiting Australian Professor of Stroke Medicine said in 2005 at a UK meeting, we invented CT, but our use of it in acute stroke is pathetic. Now, eventually, what we were able to organise was what most organised stroke units have, which involves far fewer people. Acute stroke patient is met through pre-triage, pre-notification by a stroke nurse and stroke team often. They are worked to a protocol, can request a scan directly, notify the radiographer. They then call the on-call stroke consultants if this is out of hours, and we would go in and meet the patient, or often now work virtually. And we only involve radiology if there is a difficulty in interpreting the scan, and then one can get door to scan times down to 10 minutes, and you're comfortably delivering thrombolysis in 30 minutes. So in summary, focus on supporting adoption of innovation of high value. Obviously that has a very important context of the particular healthcare system and resources available. But in all healthcare systems, you want to focus on those which deliver the greatest benefit for the lowest cost. Develop a national strategy if you can get that in place, because it's absolutely key, and then identifying the key outcomes, innovations to be adopted. Critical to get local and national audit improvement databases, and I haven't talked about it. We use PDSA, quality improvement approaches, identify champions, support the development of communities of practice, prioritise innovation that increases workforce productivity, reduces demand on stroke healthcare professionals, and look at how you can empower patients. And to summarise it all, think clinical pathway, think system. And I'll say thank you and hand back to our chair now. Thank you very much.
The next presentation will be given by Professor Bo Norvink from Sweden. Bo, over to you.
Thank you very much. Wonderful to speak to you here today. I see there are many old friends among the participants and many new friends. So welcome everybody. I will speak to you about what stroke-related changes in ICD-11 mean for practice and research. There were very many people involved in this work, and I'm sorry for the interruption. There was one working group, an advisory group on neurology, and this was chaired by Ralph Shakir from London, and also on board in this work were many representatives from different neurology associations and federations. And for stroke, it was where the World Stroke Organization came into work. I was the president of WSO at that time, so I got the task to form the cerebrovascular disease ICD-11 working group. And here you see the members of these groups. with persons from all around the world and men and females in this group. And we had a very tough task for a couple of years before we came to a conclusion. So if we go back with the cerebrovascular diseases in the ICD-10, what is found there is that stroke is in the chapter of diseases of the circulatory system, TIA is in nervous system, silent cerebrovascular diseases is in incidental imaging findings. So this looks very clear when we came to this, and the proposal that I made at that time was to say that let's have all the diagnosis code related to cerebrovascular disease in one single block and under diseases of the nervous system. So this was proposed. First, it was accepted, and very close to the finalization of the ICD-11, people at WHO all of a sudden reversed it back again and said, no, we will not change. So it was some debate, as some of you know, and finally it was decided that, yes, it should be in the diseases of the nervous system. You can see the main argument at the bottom here that it was transferred from nervous diseases in 1955, and now it was changed back to the right place. So this was diplomatics that was involved with this quite difficult task. We wrote about this in Lancet at the end of a long exile. Here is myself and Raj Zakir, and as you can see, we were quite happy that this happened and we were successful in this task. So these are the major features now of the ICD-11, that is a single block of cerebrovascular diseases, is within diseases of the nervous system. The block includes all the different manifestations of cerebrovascular diseases, and it includes definitions. So it's really a major step forward. It's a major change. It's one of the most profound changes in the ICD-11 compared to ICD-10, actually, and this has been recognized by the WHO. So stroke now is a brain disease in the ICD-11. What does it mean? And I think for brevity and the timekeeping that you can read this, but basically this comes down to statistics, policy, strategy, advocacy that is now counted as a brain disease. So the question is today that what do the stroke-related changes in ICD-11 mean for clinical practice and research? So let's go to the web page. This is the first what's come up if you browse for ICD-11 at WHO, and you could click to the ICD-11 browser, and then you come into a page which looks like this. ICD-11 for mortality and morbidity statistics. Here you have the different groups of diseases, and here you can click on diseases of the nervous system, and here rightfully placed is cerebrovascular disease. And here you have parent, you have a description, definition, inclusion, exclusions, and so forth. And here you can then continue to click and look into the details. So first of all, what is a stroke? Now there is a WHO ICD-11 definition of stroke. Stroke requires acute neurological dysfunction. This is a very important part of this. And the definition of stroke is that it's composed of cerebral ischemic stroke, intracerebral hemorrhage, subarachnoid hemorrhage, and stroke not known if ischemic or hemorrhagic. Important also is what is not a stroke. And you know there's been some debate about this. TIA is not a stroke. We took away non-traumatic subdural hemorrhage and non-traumatic epidural hemorrhage out of the stroke cases. Silent cerebral infarct, silent cerebral microbleeds are not a stroke, and the traumatic bleedings in the brain are not also counted as stroke. So this is now a precise ICD-11 definition of stroke from WHO. So I will speak about to you and give some comments on a few of all the new categories that is in the classification. First, you can see that it's not included spinal cord vascular disease, retinal infarction. This is in other chapters, and I will speak to you and give some comments on cerebral ischemic stroke, TIA, intracerebral hemorrhage. Then I will jump to cerebrovascular diseases with no acute cerebral symptom, other specified cerebrovascular diseases, and finally, before conclusion, a few words on late effects on cerebrovascular disease. So here is the ICD-11 definition of cerebral ischemic stroke. Acute focal neurological dysfunction caused by focal infarction at single or multiple sites of the brain. Evidence of acute infarction may come either from symptom duration lasting more than 24 hours or neuroimaging or other technique in the clinically relevant area of the brain. So the background you see here, that looking back on the tradition and the history, in ICD-10, the term was by pathology cerebral infarct, as you all know. It denotes a tissue injury from cerebral ischemia, and it was once thought that cerebral infarct, it was the same as acute stroke. But knowledge since ICD-10 is that more than 95% of all cerebral infarcts do not present as stroke and actually are silent. This was not known at the time of the ICD-10. There is a requirement in the ICD system that you should be able to track all the changes from previous codes to new codes and have a consistency on this between the different systems of classification. In the ICD-11, ischemic stroke is caused by a tissue injury, and the new term here is now introduced, cerebral acute ischemic stroke, which denotes the clinical syndrome, the manifestation, acute neurological dysfunction. It denotes a localization to the brain, and it denotes a pathology due to tissue injury. So this is a history, this is a background, this is focus that is caused by tissue injury and a clinical syndrome. So ICD-11 does not define the method by which tissue injury should be diagnosed. Diagnostic code acute ischemic stroke is without a time limit for clinical symptoms if a tissue injury is demonstrated. And this was very clear from the classification specialists as WSO, that if you show an injury, this is an injury. It was the same as if you have a patient with a concussion and you can demonstrate that there is a contusion, then there is a diagnostic of contusion in such a patient. If tissue injury is not demonstrated, and we know that about 15% of all ischemic strokes are imaging negative, a symptom duration of more than 24 hours is accepted as a likely fact that there is most likely some degree of tissue loss. So we have this time limit in this aspect. For transient ischemic attack in the ICD-11, this is now the reverse of a tissue-based definition. A transient episode of focal neurological dysfunction caused by focal brain or retinal ischemia without acute infarction in the clinical relevant area of the brain. Symptoms should resolve completely within 24 hours, and we have TIAs of the brain, and we have amaurosis fugax, which were also included in this part of the classification. So TIA in the ICD-11, in patients with presumed ischemic symptoms lasting less than 24 hours, if imaging reveals no tissue injury, the code is TIA. The tissue injury needs to be proven or visualized for diagnosis of acute ischemic stroke. So it means that if imaging is not done, the code is TIA. And the classification per se should not influence the clinical practice if diffusion MRI should be used or not. So this creates problem. There are several issues with the new tissue-based definition of TIA, and one is, of course, the comparability between previous data of TIA and ischemic stroke, and now adopting this to new data using the tissue-based definition. The second block of arguments is a method to demonstrate acute tissue injury is technique related and technique dependent. This is not unique for TIAs in many other areas, also in the classification, but here we have a lot of method issues. We have the problem to know if the image lesion is related to the clinical symptoms. We have many patients with multiple ischemic lesions, where many of them are not related to the clinical symptoms at all. We have the differences in use of MRI between the countries and regions. And of course, if we have a policy to do an MRI, is cost driving? Is it cost effective? Probably not. Does it change therapy? Probably not. Furthermore, we have a huge existing literature of the TIA using the time-based definition. We have other related issues like determining the duration of the symptoms. And we have also the problem of classical TIA symptoms versus non-consensus TIAs, as discussed in this wonderful article from Peter Rothwell's group earlier this year. So we used to look at the division between TIA and ischemic stroke as separate parts in the past. And I think important to recognize now that this actually is part of a continuum, and also the fact that 2/3 of all cerebral ischemic events are now TIA or mild stroke. This is from the Danish publication from the Danish Stroke Registry. We see the same proportion in the Swedish Stroke Registry now, that the proportion between TIAs and ischemic stroke is about 1:2. So this is the major bulk of ischemic events in the brain is TIA and mild stroke. And now using a tissue-based definition, we have a change here from the time-based TIA definition with these proportions. With the tissue-based TIA definition, you have the sum of the classical TIAs are now over to the mild stroke group, so have a change here. So how much does this influence this? Well, we can see in some estimates that if we use a tissue-based definition, it would decrease the rates of TIA by about 1/3 and increase ischemic stroke by 7%. So roughly this, there are some other calculations on this. So how should this be used now in epidemiological studies? We reported this a few years ago, Valerie Fagan, myself, and other co-workers, and we recommended here to study the entire continuum, not only focus on stroke, but also describe stroke and TIA in the same cohort. In the basic studies, where there is no availability of MRI, use the clinical TIA definition. In more advanced studies, present data both for the old and for the new definition. So how should we do in clinical practice? Well, what is increasingly in my mind is that I think we will need to propose to the WHO the addition of an extension code on the temporal course. An additional code, acute ischemic stroke with remission of symptoms within 24 hours. And that means that we can quantify this segment here, and we can know what is the comparability between the old and the new definition. So this is on my mind, and this is something that will be done in the near future. We have the different subtypes of the cerebral ischemic strokes, and this is from the browser, and you can see that, excuse me, very much of this is similar to the two subtypes. We can enlarge two of these: stroke due to embolic occlusion and stroke due to other known cause. And this is stroke due to embolic occlusion, and you can see that here we have the different permutations listed here in this way. And if we enlarge stroke of other known cause, this is the way it looks like in the browser at the WHO. So I just want to stress that priority in clinical practice and research: ensure that the main type of stroke is correct before you dig into the subtypes, because we will know that it will be very challenging to have the precise subtypes in clinical practice at all sites. But we more like to know really that this was a stroke or this was not a stroke, and we know it is quite common with miscodes of traumatic intracerebral hemorrhage and subarachnoid hemorrhage. Intracerebral hemorrhage, just a word on the definition here, that the classification is by location. And to this, you may combine the underlying cause, and we will come back to this, and have double coding. But it's another principle that cerebral ischemic stroke, that you subdivide by pathophysiology. Here you subdivide by location for intracerebral hemorrhage. So now a few words on the new part of the block here in ICD-11, cerebrovascular disease with no acute cerebral symptoms. And this includes silent cerebral infarct, silent cerebral microbleed, silent white matter abnormalities associated with vascular disease. This was a long discussion at WSO that should this be labeled disease? Is it pathological? The answer, as you can see, was yes. But it's important that this is not part of the diagnosis of stroke. So the definition of silent cerebral infarct is not associated with acute neurological dysfunction, but it may well be associated with other features. As we know, it was discussed the use of the term covert, hidden instead of silent. This was considered, but it was not considered to be the preferred term. Covert may be used as a clinical concept, like we use hidden symptoms after a stroke, but it was deemed not to be suitable language as a coding entity. So the official term in the diagnostic system is silent cerebral infarct. And here, this is what it looks in the browser. So number 5, certain specified cerebrovascular diseases. This part of the classification has now been updated, and here are examples of entities that may present in different clinical ways. And one example is cerebral venous thrombosis. It may present with headache, it may present with a TIA, with ischemic stroke, with a bleeding. So then you can use double coding with a clinical presentation and the underlying cause, the underlying pathophysiology, which are listed here. And finally, the late effects of stroke. Those of you familiar with the ICD-10 knew that the acute stroke codes could be used up to 1 year after the event. And it means that it was really a mess to try to determine, was this due to new stroke or was it late effect of stroke actually? Now we define that in the ICD-11 that use the acute stroke codes exclusively for the acute stroke and immediately related hospitalizations episode with an upper time limit of 1 month. So this has been specified, and I think this is also a good move. So finally, to conclude, what do stroke-related changes in ICD-11 mean for practice and research? Is one single block under disease of the nervous system. There is now an official ICD-11 WHO definition of stroke, which replaces older definitions and definitions from other sources. There is a new entity, cerebral ischemic stroke. It's no longer called that you have suffered from cerebral infarction. There is a tissue-based TIA definitions. We recognize the difficulties in comparing old and new data in TIA and ischemic stroke. We propose way forward how this can be solved. We have an updated list of causes of ischemic stroke. We have an updated list of other causes of cerebrovascular disease to be used with double coding. The block now includes silent cerebrovascular disease, and it means that the block covers a full clinical spectrum of cerebrovascular disease. So for clinical practice, you need to wait what your country officials say when at the fixed date, probably that you will make the transition to ICD-11. For research, my advice is that you should consider the ICD-11 definitions already now, adhere to the terminology and to the principles. Implementation of ICD-11 is possible to start in January next year. Most likely this will be delayed in most countries. And for your information, there is a manuscript on the background and ICD-11 coding recommendations, which are currently in preparations. So thank you very much for listening to me, and back to you, Gagana. Sorry for the technical mishap at the beginning. Thank you.
Thank you very much, Bo, for the interesting presentation. Our last speaker today is Professor Mayowa Owolabi. Mayowa, over to you.
Can you see my screen?
Yes, we can.
Excellent. Thank you very much. Can you hear me?
Yes.
Great. Thank you so much for the opportunity. I'll be talking about current deficiencies in stroke prevention, care, and rehabilitation. Essentially, this is a report of part of what we've done in the Lancet Neurology WHO WSO Commission for Stroke. I have no disclosures. Just to refresh our memories from Valerie's talk, stroke, the burden of stroke is highest in low and middle income countries compared to high income countries. And despite the fact that about 80% of the burden is borne by low and middle income countries, the resources available to combat the burden, as you can see, with this figure showing public health spending on health, is grossly inadequate in low and middle income countries in the Southern Hemisphere. So available knowledge of evidence-based interventions are not translated to reduce stroke burden in low and middle income countries. This was what motivated the establishment of the commission, and we have some publications already. Our intention is to place proof in pragmatism to make sure that the evidence available is translated to practice and policy and impact to reduce the burden of stroke. We went about this using the stroke quadrangle concepts, the interrelationship and interaction and synergy between epidemiological surveillance, health promotion and disease prevention, acute care, rehabilitation, and palliative care. As you know, surveillance is very important, just like GBD and other studies, to provide evidence for planning and designing intervention, and in fact, for monitoring the impact of intervention. Prevention is very important for reducing incidence and prevalence. Acute care is important for reducing mortality and also for reducing disability, whereas rehabilitation is focused on improving quality of life and improving DALYs. So we started off with situational analysis, and this is really what I'll be presenting today. On one of the aspects, which is prevention, we've actually gone up to solutions and gaps. For the other pillars, we are still developing our solutions and gaps through contextualization and priority setting. So essentially, we conducted a worldwide survey, global survey of stroke services and resources, and also a survey of guidelines, a systematic review and comparison of stroke guidelines in low and middle income countries compared to high income countries. And that's really what I'll be presenting today. We walked through commissioners who are appointed through a rigorous process, who are to help us not only to characterize the current state of stroke services across the globe, but also to help us map out implementation strategies, and in fact, champion implementation strategy and recruit implementation partners in their domains of influence. And all of them really extremely enthusiastic from across the globe, as you can see. So I will be presenting the results of the intervention survey, which covers surveillance, acute care, rehabilitation, as well as prevention. So the questionnaire was developed through a rigorous process and applied, and all of this is published with quality assurance and internal and external validation of the responses. So the state of stroke services across the globe, on behalf of the Stroke Experts Collaboration Group, which included the over 300 commissioners that participated, 322 commissioners from 89 countries. Data was rigorously cleaned, validated. The instrument itself was validated before use, and quality assurance process across board, including in the analysis. So the effectiveness of stroke guidelines, we followed PRISMA guidelines, and of course, this is registered in Prospero. This is published in WHO bulletin, the bulletin of the World Health Organization. We reviewed guidelines for stroke, different aspects of stroke care, surveillance, prevention, acute care, rehabilitation from 2010 up to 2020, and we compared, we were able to retrieve 108 eligible guidelines from over 47 countries. A lot of the low and middle income countries had no guidelines for review. We used the Institute of Medicine instrument of criterion for quality of guidelines, which included transparency, conflict of interest management, multidisciplinary development group, whether it is based on systematic review and best evidence, articulation of recommendations, external peer review, and date of future review, whether that is planned. And you will see that low income countries fared worse on most of these criteria, compared to high income countries, as you can see. Similarly, we looked at the 4 pillars: surveillance, primary prevention and secondary prevention, acute care, and rehabilitation. We looked at coverage of these various pillars by the different guidelines. And you will also see that guidelines from high income countries actually covered these domains better than those coming from low income countries. And none of the guidelines, this is a huge gap, covered surveillance, monitoring, and evaluation of impact. So this is a huge gap that needs to be addressed. This summarizes our findings according to GBD super regions, WHO regions, for the different pillars in terms of stroke services available. And you will see that globally, regardless of the country income level, that less than half, have access to stroke surveillance, prevention, acute care, and rehabilitation is actually the least. And for pockets of area where you have moderate access, they are really actually high income locations. So we will then take them one by one, each of these 4 pillars. Starting with surveillance, you will see that Russia, Mexico seems to have stronger surveillance systems. In Africa, for instance, most of the countries, no data is available for stroke surveillance. And most of the low and middle income countries are either performing poorly or they actually reported that they have no surveillance systems. We did not obtain any data from quite a number of low and middle income countries. Prevention, well, for primary prevention, it's actually the worst. And you could see a lot of red zones. And the only green zones are actually in the high income countries. So primary prevention of stroke services for primary prevention of stroke is not good enough, particularly in low and middle income countries. Secondary stroke prevention is a little bit better, but it's still worse in low and middle income countries. So, of course, this makes it not so surprising, the fact that the burden of stroke, which is actually in pandemic proportions, as Valerie put it, in low and middle income countries continue to ravage because preventive efforts are really not strong enough. This is from our collaboration with the WHO. The WHO NCD Survey 2019 also looked at risk stratification for prevention of stroke, heart attack. As you know, they all share similar risk factors. And when you look at countries that really do not have this risk stratification for prevention, you will see that low and middle income countries are the worst affected. The high income countries tend to have more than 50%, of these parameters. For acute care, the story is also similar. The guidelines that have various components of acute stroke care for middle-income countries and mostly for high-income countries is by far better than what you see, the guidelines coming from low-income countries. in different areas: pre-hospital care, blood pressure, fever, glucose, edema, seizures, ischemic stroke ICH, subarachnoid hemorrhage, thrombolysis, and so on and so forth. So we also evaluated participating countries and hospitals in terms of the WSO roadmap for stroke control, which classified services for acute care into minimal services, essential stroke services, which includes minimal services, advanced stroke services, which also includes essential stroke services. And you will see that even for essential stroke services, as you can see here, you see that low income countries, only 5.9% had essential stroke services. Low middle income countries, only 14.3%. Upper middle income countries, only 20.2%. But when you look at advanced, which includes everything essential, in addition, high income countries are doing, and upper middle income countries are by far doing better than low middle income countries and low income countries. So this is also shown in our survey of stroke services, not just the guidelines. And you will see that the low and middle income countries are not doing very well with respect to acute stroke services. And when you break it down and look at presence of acute stroke, any stroke unit, for instance, you will see that, in fact, there is a gradient in terms of presence, in terms of number and quality of stroke units available. There's a gradient going from low income country to lower middle income to upper middle and to high income countries setting. Similarly, the WHO NCD survey also looked at acute stroke and rehabilitation care and compared for acute care, which is the blue bars, and the rehabilitation for stroke, which we can see. And you also see a similar gradient going from low income to high income country, in not only in acute care, but also rehabilitation. So in more than 194 countries. So for rehabilitation specifically, looking at guidelines, stroke guidelines, you will see that most of the guidelines, particularly from low-income countries and middle-income countries, do not have components of their guideline addressing basic components such as dysphagia management, prevention of DVT, depression, education, physiotherapy, nursing, speech, and cognitive rehabilitation. And when you look at services, rehabilitation services, also no data is available in many low and middle income countries, and where available, as you can see, rehabilitation services delivered after stroke is either poor or barely acceptable. And when you look at the details also, there's a gradient going from low income country to high income country. Now, this is very important. We looked at all stroke guidelines across all the different income levels and saw whether they not only developed the guideline, but also included how the guidelines will be implemented in terms of translatability, implementation plans, dissemination plans to all stakeholders, and research recommendations for gaps where they couldn't really find strong evidence to make recommendations for intervention, economic considerations, social considerations, legal considerations, ethical considerations. We saw that across board, less than 50% of guidelines, even in high-income countries, address these issues. So, in conclusion, both LMIC stroke guidelines and services are inadequate compared to high-income countries. We plan to publish in series. We already published some, but the full report and recommendations of the Commission across the 4 pillars of the stroke quadrangle. We also plan to launch the implementation plan an ecosystem for implementation, and using the principles of the implementation cycle, and of course, an interactive website to monitor things, and eventually also a post-intervention survey to see to what extent we've been able to address the SDG 4. We are familiar with the implementation model, implementation science model, that for behavioral change, guidelines are not only what is required, but are fiscal measures, regulation, service provision, legislation, communication, marketing, social planning, environmental, so many factors, education, persuasion, all of these are important enablement to really deliver impact and reduce the burden of stroke. So therefore, we are following the implementation cycle, contextualizing evidence, and then communicating with relevant stakeholders, and then reviewing our impacts and rejigging the way we deliver the implementation to ensure that we are able to bring down the burden of stroke, particularly in low and middle income countries. And we are proposing the establishment of the global stroke control and observatory and risk reduction ecosystem as part of the Lancet Commission, which includes the Operations Committee, Steering Committee, working with sister and relevant Lancet commissions for other NCDs, working with the United Nations, World Economic Forum, the World Health Organization, implementation partners, and the commissioners we mentioned earlier on, but also not only policymakers, but also patients, caregivers, families, payers, the general populace, providers, practitioners, and physicians. We want to acknowledge everybody who has participated and supported this, including the Lancet Neurology, WHO, WSO. And we want to invite you to the first ever African Stroke Organization Conference holding in November 3 to 4. Thank you so very much for your attention and for your support.
Mayowa, thank you very much. And I would like to thank all the speakers about the valuable information and the great presentations. Now it is my pleasure to introduce Professor Agri Hills, Professor of Neurology, Physical Medicine and Rehabilitation, and Cognitive Science at Johns Hopkins University, who will be moderating the Q&A session. Argi?
Thank you very much. There are some very nice questions in the chat box that we could address. Several are really for Bo about the ICD-11. So is the transition to ICD-11 country specific, and when will it be launched?
Yes, thank you. No, it was officially approved by the World Health Assembly. I think it was 2019, and it's set to start. You can start it at January 2022, but each country decides when it will move over to ICD-11 because it's a huge work to do. It needs translations, it needs changes in the hospital systems and the coding. So each country decides when it will make the transition. I know no country that will start right off next year in January. I think most countries will have a few years to prepare for this, but I think we should be mentally prepared, and I think also for research purposes that you should have the ICD-11 in mind already now. Thank you.
Great. And there are a few people who have questioned the TIA definition. One person said maybe covert brain infarction rather than silent stroke due to the risk for stroke and dementia and so on.
Yeah, thank you. This term was discussed and very thoroughly discussed, and it was not favored largely because it was not considered to be a good language to say that you have a hidden disease, you have something which is hidden, and here you have a diagnostic code with something which is hidden. You have a code for something which is demonstrated and specified rather than the other way. So I think there is a definition, and it can be useful and adhered to, and it should be workable.
And then another question, and this may have to be our last, is about rehabilitation as an advanced service. According to the UN, rehabilitation is a human right. And and this is a human right, how can we move rehabilitation up the priority list? Not sure which of the panelists would like to take that one on.
Okay, I think I probably would address that.
Yes.
Rehabilitation is a right. And so every patient or every stroke survivor, and that's why we went on with the principle of the stroke quadrangle. We want to, first of all, prevent stroke. If we don't succeed and people develop stroke and they have acute stroke, we want to give them the best so they can survive the stroke. Then if people survive stroke, the next step is we want them to have the best quality of life and to reduce disability. So it's a right. So those four pillars are all very important. None is more important than the other, even though we feel that prevention probably pays off better in terms of being more cost effective than other interventions. But if a patient has already developed a stroke, then we need to ensure the best acute care is made available and the best rehabilitation services is made available to improve the quality of life of such an individual.
Great.
It's also a very high priority.
I can add to this, to the question, how to make rehabilitation one of the priority areas for policymakers. I think you need to show the burden of stroke in terms of the outcomes, functional outcomes, show the financial burden of stroke in the country, and secondly, you need to show policymakers the effectiveness and practicability of using some rehabilitation techniques in the country. Then they may be convinced that it is one of the priority area.
Right, I agree. And I think that that is actually all of the questions. We have many, many comments from attendees throughout the world, mostly thanking the speakers for their excellent presentations. And I have to agree, we are right on time. And it's been a wonderful presentation with lots of good information that people can use in every country. And I so appreciate all the people who have come from virtually everywhere in the world. And it's 7:30 in the US, and so it's time to end. But thank you again for all the panelists and for the wonderful talks and for the attendees and their attention.
Thank you, everyone.
Thank you, everyone. Thank you.
Thank you very much.
Thank you very much. Have a nice day.
Thank you very much.
Bye.